not making a presentation at the same time. Okay, so station two
Finish
is
the story though.
yeah.
What's the rest? What's the rest of the story? What happened?
Nothing. I just
Nothing.
replied to him. He went into a private doctor, and the private doctor done Rene and Weber. So the private doctor is more efficient than me, and then prescribed oral steroid and the automized spray.
So wrong.
Yeah, for Eustachian tube dysfunction or ciprofloxacin. Ciprofloxacin eardrops here, and that's why the private doctor is much more efficient. He knows more than me. Anyway, anatomy and physiology of the Eustachian tube. That's what we're going to be talking about. Definition of Eustachian tube dysfunction, symptoms and signs, how you can diagnose it, treatment, and finally differential diagnosis. Yeah, differential diagnosis. Okay. So quick picture about the anatomy. We all know the anatomy. I'll have to crack on because we don't have much time. But anyway. Which side is this one? Huh? Left. That's a left Eustachian tube. Tubal, torus tubaris, posterior pharyngeal wall. Your Eustachian tube is here. How much is cartilaginous and how much is bony from the Eustachian tube?
2/3 cartilaginous.
2/3 cartilaginous and
2/3
opposite to which structure you get 2/3 bony, 1/3 cartilaginous. I'm asking like so basic questions, but the difficult question is the angle between the bony and cartilaginous part in adults. What is the angle?
It's more flatter,
Flatter, yeah,
more acute.
160 degrees exactly. Tell me about the Eustachian tube in children. What is the problem with the Eustachian tube in children? Come on, this is like basic.
Acute angle
Shorter?
and more of an angle. Acute.
No, it's the opposite. It's more horizontal, more horizontal. So in children, the angle between the Eustachian tube and the skull base is more horizontal. That easy stuff can reflux from the nasopharynx into the middle ear, while others is 45 degrees, so against gravity. So they have to climb to get into the middle ear. So shorter, more flatter or more flexible, and it's more horizontal. That's in children. Okay. Yeah, come inside. Two muscles operate on the Eustachian tube. Dave? Levator? Single levator. Levator patini, that's a good muscle. And tensor, which is more efficient or which is more important? Tensor. We have tensor. Tensor. It's the elevator. So the elevator is actually has to action first to give the scaffold for the tensor to work on. So the levator is more important. That's why in cleft palate, the levator is not working properly. That's why they get middle ear effusion and Eustachian tube dysfunction. Function of the Eustachian tube. We'll get to the physiology, but what is the function of the Eustachian tube before we go to the physiology?
Balance the pressure.
Balance the pressure. Why do we need to balance the pressure?
Proof the hearing.
No, why? What happened in the middle ear that needs continuous?
Because there is exchange of air going on.
Exactly.
So
we move into the physiology part. Okay, this is a picture of the Eustachian tube when it's closed and when it's open. The bony part doesn't move. It's only the cartilaginous part which moves. Okay. And we said we need the levator palatini, tensor palatini. You have also the salpingopharyngeus muscle related to the Eustachian tube, and you have the tensor tympani muscle close to the Eustachian tube, and it takes origin from the Eustachian tube. So we have continuous bidirectional diffusion. Carbon dioxide moved from the blood vessels going into the middle ear cavity, while oxygen is going from the middle ear cavity into the blood vessels. Okay, and we need to replace the oxygen going from the middle ear cavity into the blood vessels by opening the Eustachian tube. Okay, the pressure that stays inside the middle ear also protects from reflux of content from the nasopharynx, because it always from the high pressure into the low pressure. Okay, so if you have a high pressure into the middle ear, it will prevent the reflux. Yeah, from low to high, sorry, from high to low. Okay, from high to low. So if you have a high in the middle ear, the pressure in the nasopharynx will not allow refluxing of contents into the high pressure. So when you get eustachian tube dysfunction, you propose yourself for infection, reflux. So one of also the other function of the eustachian tube is to drain any mucus fluid in the middle ear and to prevent reflux of material from the nasopharynx into the middle ear. So these are the two functions. So the eustachian tube is not doing I'm stupid.
Yeah.
So if the eustachian tube is not ventilating the middle ear or is allowing pathogens to go into the middle ear, we'll say it's dysfunctioning. It's not doing its function properly. We don't have time to talk about macroventilation and the microventilation, but this is basically the physiology. So like we said, eustachian tube dysfunction is inability of the eustachian tube to do its function, either regulating the air pressure, allowing air to go inside the middle ear cavity, or prevent reflux of material from the nasopharynx into the middle ear. Okay. Incidence around 1% of the population, so it's not that common. More in males, could be we smoke most of the time. Okay. No significant statistically difference in seasons, so it can happen summer, winter, anytime. Types either acute, less than 3 months, or chronic, more than 3 months. Categories, we'll talk about the categories in more detail. So we have the power challenge induced, we have Patulous eustachian tube, and we have dilatory eustachian tube dysfunction. Let's talk more about the categories. So power challenge in this power challenge induced eustachian tube dysfunction, we all had it at one point or another. We all traveled in airplane and we all experienced changes in the pressure. So basically the eustachian tube will fail to open due to the surrounding pressure changes. And with chronic equalization, the mucosa also suffers from trauma with frequent valsalva maneuver, and you get the changes in the eustachian tube after the barotrauma. Can persist in some population. I think that patient's mom traveled, but it was like 3-4 months before her symptoms. So that's why I didn't link it much to eustachian tube dysfunction. Anyway, we'll see why it's difficult also to diagnose eustachian tube dysfunction. You get normal otoscopy and tympanometry. That's one of the things that make it hard to diagnose. So basically the patient is normal. We'll get to the symptoms and how possibly we can diagnose eustachian tube dysfunction. Normal otoscopy, normal tympanometry. You can see some inflammation and mucosal edema over the torus tubaris. Can also be visible, however, not all of the time. That's power challenge induced eustachian tube dysfunction. If it persists more than 3 months, that's a chronic eustachian tube dysfunction. Less, it's acute. Patulous eustachian tube. Who are the type of patient that get patulous eustachian tube? No.
Elderly.
No. It could be elderly, but any
Those have lost weight.
who lost weight. So ladies who lost significant amount of weight, they get patulous eustachian tube dysfunction. You seem surprised, but that's typical for. Well, it's basically the eustachian tube is closed most of the time. Okay, if it's open, you start listening to your own voice, and you get autophony. Tell me more one thing that can cause autophony.
No clue.
Okay, Cybo, what can cause autophony? You have to know that.
That
Exactly. Severe semester canal dehiscence. So differential diagnosis for autophony mainly patulous eustachian tube and superior canal dehiscence. And when they are listening to themselves, they will start trying to equalize the pressure because they can hear their own voice inside their head. Patient gets surprised when I ask them, "Can you hear your own voice inside your head?" And you get like, "What's this question?" But if patients with severe semicanal dehiscence or patulous eustachian tube, you say, "I can hear my own voice like a speaker inside my head." Bilateral eustachian tube, females who lost the weight. Dilateral eustachian tube dysfunction means it's not dilating because inflammation and mucosal edema. What is the common thing that can cause dilatory? Common cold, yeah. Give me sinusitis, allergy, and the most dangerous thing is
Okay.
not really
Cancer?
cancer. So you have to rule out nasopharyngeal carcinoma in these patients. Okay. Symptoms and signs. Now we're trying to get into something. So pressure in the ear. The patient will tell you, I feel pressure in my ear. Is any pressure in the ear eustachian tube dysfunction? Really difficult. Come on, Asif. You missed a bit, but it's right. Any pressure inside the ear? Difficult because we will get pressure inside our ear. What else patient can complain of? Pain, not common. What else? Feeling it's clogged, like someone is putting his finger in your ear. That's feeling that you best especially with Meniere. Tell you my ear is full, like someone is literally blocking my ear. So clogged ear or under the water. The 7 symptoms, they are called 7-item eustachian tube dysfunction questionnaire, and it's important. It will help you in diagnosing them. In UCLH, we used to have them printed and we'll give them the patient because it will help with diagnose and monitor the treatment. If you do any treatment, you want the symptoms or the main average of the symptoms to improve, ETDQ7 to improve. Other is, do you have ear symptoms when you have cold or sinusitis? Crackling or popping sensation in the ear, it's all non-specific. That's the problem with eustachian tube dysfunction.
I can make my ear pop
Exactly.
voluntarily.
And they come to me because they say, one of the patients, I can't pop in my ear. It's sometimes it's really difficult. What are they?
Just go
Okay,
back.
sorry. Okay. Ringing in the ear, the 6th one, 7. Feeling that your hearing is muffled. That's the 7th. So the mean, you give the patients these 7 symptoms and they score each one from 1, nothing, to 7, as severe as it could be. You get the score and you divide it, and the mean, if the mean is more than 2, you possibly have eustachian tube dysfunction. If less than 2, you don't have eustachian tube dysfunction.
But some of these are similar, like your
Exactly.
ear being plugged. and
Exactly.
muffled.
Exactly. That's what the difficulty. You will see a slide saying, let's show you. Go back. Lack of clarity, defined diagnostic criteria, and the uncertainty relating to the etiology of eustachian tube is a key challenge in undertaking a review of intervention. It's difficult to diagnose eustachian tube dysfunction. So this can help you to diagnose eustachian tube dysfunction. However, like possibly if the patient was traveling or just after traveling and he got like pressure in his ear, fullness in his ear, muffled sensations, pain in the ear, ringing, clogging, and you give him the questionnaire is high, possibly he has eustachian tube dysfunction, most likely. So you keep treatment and see how it goes, like most of the time that we do.
Is the duration of the symptoms?
So acute less than 3 months, more than 3 months is chronic. History, so you asked about precipitating factor. As we discussed, do you have reflux? Because reflux can also cause edema, giving you dilatory eustachian tube dysfunction. Any allergies, any recent upper respiratory tract infection or common cold? Have you had adenoidectomy? Any family history of eustachian tube dysfunction? Could be any genetic cause of them. Any something causing reduced mucociliary clearance, Cartagena syndrome or cystic fibrosis, Down syndrome, and cleft palate. Because in Down, the muscles are not working properly. Cleft palate, the elevator is not working properly, not even the tensor as well. Any smoking at home or allergen, the hiking or high altitude, traveling, frequent travelers. So ask about the occupation, flight stewardess, any medication, oxymetazoline and corticosteroids. Okay, this is your history, and this is the adenoid. That's a nice, good picture. So this is the eustachian tube, normal one, trying to open. So when the torus tuberous, it rotates medially to open the eustachian tube medially. In this picture, what happened is a patient with adenoid, when the superior constrictor of the pharynx is compressing the food, is trying to swallow or trying to swallow saliva. The superior constrictor push the adenoid, and the adenoid push the torus tuberous into the suction tube. Like you're not opening today. So it pushes it, prevent it from medial rotation, or even like block it. That's the effect of the adenoid on the suction tube. That's why they get glow air, and what's why in recurrent glow air it's preferable to remove the adenoid as part of the operation. Examination wise, otoscopy, you can get normal otoscopy. You can see retraction, but sometimes it's absolutely normal. Okay, you have to do flexible endoscopy. First, you're going to see the opening of the suction tube. So I just ask the patient to swallow when you're looking. You see just like medial rotation, slight rotation of the torus tuberous medially and posteriorly. Okay. You see the mucosa, see any inflammation or edema in the nasopharynx, and most importantly, cancer. If any post-nasal mass, you're looking for that. Reflux as well, have a look at it. Have a look on the contralateral nasopharyngeal orifice of the suction tube. Just angle the scope and have a look on the other side. Dilatation, okay, with the swallowing, and of course, any neck mass, cancer. The nasopharyngeal carcinoma or any other cancer. So more than one patient came to me was with MS. I don't know what's the connection between MS and suction tube dysfunction, to be honest. But that's what both of them came to me with symptoms of suction tube dysfunction. What investigation you're gonna do?
Tympanogram.
Tympanogram, of course. Anything else?
Audio.
Gonna do audio. Brilliant. Whoever so the patient doesn't complain and say you're not a patient. I had to reply in like a massive emails. It's like but around 50 to 60 paragraphs.
You're nice. Last time I got asked to write an apology to the patient, I just said no. Matron's job.
Should have done that. So treatment options, we can divide it into conservative approaches and medical or surgical approaches. Conservative medical, saying to the patients like, let's try step-ladder approach. Let's try conservative active observation, like doing nothing, keep popping Valsalva maneuver and see how it goes. Autovent balloon can help. So
That little balloon thing.
yeah, from Amazon, 8-9 quid. They keep breathing in it. It helps children, so hopefully it will help adults. Yeah. And it's just like a way, because patients want something. You can't just like he came to completely say, okay, let's see how it goes, go home. He wants something. So autovent balloon is not gonna harm. If it didn't do good, it's not gonna harm. So try autovent balloon 3 months, and I'll see you back again. Hopefully, when he comes back, someone else of your colleague will see him. Exactly. Valsalva maneuver, like we say. Avoid allergen as potentially treatment of rhinosinusitis, gastroesophageal reflux. It's all conservative treatment. Antihistamines, nasal corticosteroids, decongestant if he's like what do you call it? Congested or dilatory type. Otrivine 7 days, and then pseudoephedrine for another 7 days or 10 days. Let's see how it goes. If you reduce the edema, if it's gonna help.
I like Neomed.
Neomed can be helpful. Yeah, just like to wash and.
Because it's like quite extreme to shove 20 mils of water up your nose. So you kind of find your patients all of a sudden get better.
Okay. We can prescribe. Yeah, again, the guy kept saying the private doctor prescribed oral corticosteroid, but I'm gonna give oral corticosteroids. Seriously.
The risk is.
Exactly. Which I said you're gonna harm. It's gonna cause harm more than good. Surgically, we have associated tuboplasty. Anyone used it? Anyone? Tube balloonoplasty?
I think I've done the tube plastic.
You done it?
Tube, but not for the Eustachian, it's like scientists, but it's the same.
Oh, first,
They do the same instrument, isn't it? You just
Well,
change your angle.
I have a look on a video. It's almost the same, yeah.
Okay, when you do FNE, can you just go in and poke the tube?
With what?
Was the FNE like, you know?
I'll show you the video. You know why you can't do that. I'll show you a video of precision tuboplasty. It goes inside the Eustachian tube. You inflate it with a pressure of around 12 watt. Usually the rib comes with us in UCLH, and you just inflate it with water, leave it for 2 minutes, and then deflate and take it out. Okay, I'll show you the video. Anyhow, you supposedly these 2 minutes will change the patient's life. Okay, we'll get to that point. But the patient also, one of the complaints he wrote about me, why I didn't discuss with his mom Eustachian tube tuboplasty. Because I did the tube tuboplasty, and we'll get to that how efficient is balloonoplasty. Okay, from the NHS or NICE guidelines. Grommet could be.
Yeah.
Some surgeons put grommets in there. Adenoidectomy for sure can help in children or even adults with large adenoids, can be helpful. Eustachian tuboplasty without balloon, the idea is try to scar the torus tubaris to the posterior pharyngeal wall. So with the scarring tissue will pull the torus tubaris medially, keeping the tube open. Okay, the problem with that is you may end up with pattern Eustachian tube that's open all the time. And the patient will, from dysfunction into hearing their own voices and infection all the time. Okay, that's why I put question mark around it. Okay, so Eustachian tube balloonoplasty. Let's try to show you a quick video.
You think it's clinic, but
Yeah, the clinic.
Sarah.
Okay, say bye.
our clinic started.
I did. We almost had it.
You know, we put this in. You know, I thought.
Me. Okay.
And what is it all for all afternoon?
From 12 to 1, I'm almost finishing. Like we're done, almost finishing.
You're really finishing?
Nearly finishing. Last two
It's
slides.
just that
I know.
somebody's outside with
Sure. Yeah, yeah. Last two slides.
Thank you. More.
So let me just let me already said.
It's 16. Oh, text all the other users are to this out. So, yeah. Because. Which secretary gave it to you?
Yes.
Children recognise.
Sorry, man, I didn't know what time it started. Was it?
That's right. Oh, he's doing it. Okay. Okay. So yeah, let's go back a bit. So you go through the nose with this tube exactly. Inferior turbulence. Okay. Yeah. It's just like fiddly. Yeah, exactly. So you have to keep watching the tip of your tube, and he's doing it with the camera. And then once you get into the Eustachian tube, you have to be inside. Okay. Anterior to you is the carotid. So you insert, and you have to go all the way in, and then you dilate for 2 minutes. Okay, and then you just
It's cartilage. It's kind of flexible.
exactly. This is the thing.
Bounce back.
Exactly. So you end up with this. Other things can happen. So one of the complications for this procedure is you can end up with a stroke. I've seen a patient after Eustachian. Yeah, not theoretically. Yeah, because you're near the carotid, internal carotid. So the patients after Eustachian tube balloonoplasty, she was aphasic, paraplegic. And they called me after I went home. They said that your patient is not talking and is also in seizures. Like seriously, I didn't do anything. It was after she went into the neurosurgery, the MRI scan, blah blah blah. Everything was normal, and then she started talking. I think she was hysterical or something, but it was normal. Okay, I think the guidelines will be in the next. But to give you a quick idea, because we didn't have much time. Okay, so basically, NICE guidelines say it's 50-50. If it worked, brilliant. If it didn't work, don't repeat it. There is no benefit from repeating it. Okay, and most of the papers that I read, I'm not gonna bother you with the numbers. Around 54%. The most optimistic was 66%. So you tell the patient it's 50-50. It can be done under local anesthetic and general anesthetic. So if the patient's happy to take the risk, you can go for it. Okay, I was going to talk about indications. So you need chronic eustachian tube dysfunction, we say more than 3 months. Failure of medical treatment. Step letter, give the patient conservative treatment first. If it didn't work, try eustachian tube dysfunction, try eustachian tube pyelonoplasty, and if you want grommet, you can get over them grommets. If it's type C tympanogram, I wouldn't do it without type C tympanogram, to be honest. Like normal type A and patient wants tuboplasty, I would be hesitant. But if it's type C, I may offer it to him. And high eustachian tube dysfunction questionnaire 7. So you can monitor after that. If you done the tuboplasty and then the patient comes back to you, you give them the questionnaire, the mean average is reduced, it could that you help them. And I think it's most likely placebo effect. Because like we said, eustachian tube dysfunction is hard to diagnose. Effectiveness, we talked about possible complication. I give you one, carotid may come, and you may end up the patient having from dysfunction into what? Bacterial eustachian tube. And yeah, so scarring of the eustachian tube can happen as well. So you end up with more dysfunction. Hemotemperam, also one of the risks of eustachian tube dysfunction, otitis media and tinnitus, because of the eustachian tube now is more patent, so pathogens can easily go into your middle ear cavity, causing more infection. But eustachian tube, emphysema, adenoma mediastinum, I've never seen it, to be honest. But theoretically, if you injure the nasopharynx, you may have this complications. Any questions?
What do you do for bacillus eustachian tube?
Good question. Bacillus eustachian tube. What do you think?
Block it out?
You try to block it up. So Ian Bottrell in Oxford, he wrote like a big chapter, and he was really fan of Bacillus eustachian tube. So trial of injection of saline posterior to the torus tubaris. Tried, I didn't get absorbed. So he tried fat, tried hydroxyapatite, anything trying hydroxy like calcium. What's called it? The radis, Restylane or radis. The one injected the vocal cord.
Yeah.
Yeah. You can try, but you also risk you may end up with eustachian tube dysfunction. So it's like trying to hit the balance. Okay. Any other questions, guys? You're happy now to diagnose? Oh, but I recorded it.
Fat injection.
You can try fat injection, yeah, as well. Okay. I hope I'm recording. Stop recording, yeah.